CVS Part 1, Case 11.
A 46-year-old woman presents with progressive exertional dyspnea, fatigue and intermittent dizziness for 14 months. Over the last 4 months, she has developed mild ankle swelling and reduced exercise tolerance, now becoming short of breath after climbing one flight of stairs. She denies chest pain, fever, cough, hemoptysis, syncope, orthopnea, paroxysmal nocturnal dyspnea or prior venous thromboembolism. She has no history of chronic lung disease, connective tissue disease, congenital heart disease, liver disease, HIV infection or exposure to anorexigens or methamphetamines. She has long-standing hypertension and obesity. Her medications include amlodipine and hydrochlorothiazide. She is a non-smoker. On examination, blood pressure is 148/86, heart rate is 96, respiratory rate 18, oxygen saturation is 95% on room air. She has a loud P2, right ventricular heave and a mild JVP. Lung fields are clear. A soft tricuspid regurgitation murmur is heard at the left lower sternal border. There is a trace bilateral ankle edema. ECG shows sinus rhythm, right axis deviation and right ventricular hypertrophy. Chest X-ray shows enlarged central pulmonary arteries with peripheral pruning and no interstitial lung disease. Pulmonary PFT includes DLCO or normal. High resolution CT chest is normal. A ventilation perfusion scan is low probability for chronic thromboembolic disease. Echo findings: left ventricular ejection fraction is 55%, mild concentric left ventricular hypertrophy, mild left atrial enlargement, grade 1 diastolic dysfunction, dilated right ventricle with reduced systolic function. Estimated pulmonary artery systolic pressure is 76, moderate tricuspid regurgitation, interventricular septal flattening. Right heart catheterization shows RAP is 11, pulmonary artery pressure is 80/36, mean is 53, PCWP is 17, cardiac output is 4.8, cardiac index is 2.4, pulmonary vascular resistance is 7.5 Wood units, mixed venous oxygen saturation is 61%. Which of the following is the most appropriate next step in management? Option A. Diagnose idiopathic pulmonary arterial hypertension and initiate high-dose prostacyclin therapy immediately. Option B. Diagnose isolated pulmonary hypertension due to left heart disease and treat only with diuretics and antihypertensive therapy. Option C. Treat as combined pre-capillary and post-capillary pulmonary hypertension. Optimize left heart filling pressures and systemic blood pressure and refer to a pulmonary hypertension specialist center before initiating targeted therapy. Option D. Diagnose chronic thromboembolic pulmonary hypertension and initiate lifelong anticoagulation with surgical evaluation. Option E. Reassure the patient that findings are attributable to obesity alone.
So this is a case of combined pre and post capillary pulmonary artery hypertension. Now the very important and high yield concept which we need to take care of is that in a combined pre and post capillary PH, the primary driver is the left heart disease. The left heart failure, as explained prior also, leads to a backward pooling of blood in the left atrium and then to the pulmonary circuit, which chronically leads to the pulmonary vascular remodeling and later on can lead to right heart disease. So in this case, if we prematurely address the pulmonary vascular resistance first, that is the pulmonary arterial disease is if primarily addressed, then it will worsen the condition, because premature initiation of pulmonary vasodilators is anyhow going to worsen the filling pressures and create more congestion. So first the left heart disease has to be optimized. Now how will we optimize the left heart disease? We'll optimize the left heart disease by careful diuresis, first decreasing the filling pressures and addressing the systemic hypertension, the underlying systemic hypertension with antihypertensives, and then we will send the patient to a specialized center taking care, targeted care for the pulmonary arterial disease. So this is the right thing to be done. Now excluding the wrong options and selecting the right option,
Option A is diagnose idiopathic pulmonary arterial hypertension and initiate high dose prostacyclin therapy immediately.
So again, as discussed, it is not idiopathic pulmonary artery hypertension, first thing, and high dose prostacyclin therapy given immediately will further worsen the situation. So option A is wrong.
Option B is diagnose isolated pulmonary hypertension due to left heart disease and treat only with diuretics and antihypertensive therapy.
Again, this is important that only addressing the left heart disease will also not solve the situation, because the pulmonary vascular resistance is very high here, 7.5 Wood units. So this high pulmonary vascular resistance will become a reason for increased afterload for the right ventricle and will lead to the right ventricular failure. So after optimizing the left heart disease with antihypertensives and careful diuresis, we need to address the high PVR by prostacyclin, sildenafil, tadalafil and other therapies. That will solve the situation here.
Option C is treat as combined pre-capillary and post-capillary pulmonary hypertension, optimize left heart filling pressures and systemic blood pressure, and refer to a pulmonary hypertension specialist center before initiating targeted therapy, which is the correct option.
Right.
Option D is diagnose chronic thromboembolic pulmonary hypertension and initiate lifelong anticoagulation with surgical evaluation.
So this is again wrong, because lifelong anticoagulation therapy with surgical evaluation is of no use in this case.
Option E is reassure the patient that findings are attributable to the obesity alone.
It is not attributable to obesity alone. So this is not going to solve the case.
Search Edumedex on Instagram and YouTube to start your journey today.